Welcome to the crumbling world of chronic liver disease. This is the final installment of our three-part series on abnormal liver tests. In Part 1, Abnormal Liver Labs, we introduced three lab patterns: hepatocellular, cholestasis, and isolated hyperbilirubinemia. Then, in Part 2, Acute Liver Disease, we cover disorders that present with an acute hepatocellular pattern. Now, here in sketch number 3, it's finally time to focus on the chronic side of the hepatocellular pattern. If you haven't already, you may want to check out those first two sketches. Without further ado, let's travel back in time and space to an island in ancient Greece. The year is 350 BCE. Already, this land is steeped in history and ruled by a cornucopia of gods, myths, and monsters. You never know what's lurking around the corner. Before getting too caught up in mythology, let's review the basics. The hepatocellular lab pattern is seen in diseases of the liver parenchyma. Injured hepatocytes tend to leak intracellular enzymes like AST and ALT into the serum. The result is a pattern characterized by disproportionate elevations of AST and ALT, sometimes accompanied by lesser elevations in alkaline phosphatase. Notice the toasting malt shakes above the chalk bucket. Serum GGT may also be elevated, often in parallel to ALK Phos. As you may recall from our last sketch, hepatocellular disease is considered acute if illness duration is less than 6 months. Anything longer is considered chronic. Acute and chronic hepatocellular disease also differ in other ways, like the degree of elevation in aminotransferases. Acute hepatocellular injury typically presents with marked elevations in AST and ALT. We're talking greater than 15 times the upper limit of normal, hundreds or even thousands. The numbers are less impressive in chronic hepatocellular disease. This time, expect mild or moderate elevations in AST and ALT. By definition, this means less than 15 times the upper limit of normal, which translates into values in the double digits or at most a few hundred. But keep in mind, in hepatocellular disease, AST and ALT will always be more elevated than alkaline phosphatase. This relationship remains true even if AST and ALT are only mildly elevated. In such cases, the ALK Phos is often in the normal range. Before we move on, let's get some terminology straight. Hepatocellular disease and liver disease are often used interchangeably. However, in the chronic setting, hepatocellular is a more narrow term because cholestatic disorders can also cause chronic liver disease. Hint, hint, this will come up again later. As a result, we'll use the more narrow hepatocellular whenever possible. Also, be aware that we use hepatocellular injury and hepatocellular disease interchangeably. Disease tends to be used more often in the chronic setting, so expect to hear this word quite a bit. Most of this sketch is devoted to the individual causes of chronic hepatocellular disease, but first we'll cover some common features. Each of these diseases can be roughly divided into 2 stages, an early, minimally symptomatic stage and a late stage characterized by development of cirrhosis. Let's take a closer look. The early stages of these disorders are often classified by their appearance under the microscope. Diseases that are inflammatory from the start are appropriately categorized as chronic hepatitis, hence the fiery torch near the liver-shaped sign. In other conditions, the earliest stage is hepatic steatosis, that is, fatty infiltration of hepatocytes in the absence of inflammation. However, if the disease is allowed to progress, inflammation may begin to develop alongside that fatty infiltration. This second, more advanced stage is called steatohepatitis. Regardless of which category the condition falls under, patients in the early stages of chronic hepatocellular disease tend to have some common features. For one, they're often asymptomatic. In fact, at this stage, abnormalities on routine lab tests may be the only sign of disease. Which labs, you ask? A chronic hepatocellular pattern, of course. Look for that mild to moderate elevation in AST and ALT. In some cases, alkaline phosphatase and GGT may also be elevated. Importantly, serum bilirubin remains in the normal range at this stage, so no jaundice. An abdominal exam may reveal hepatomegaly in some patients. In others, physical exam may not demonstrate any signs of liver disease. In some, patients with early chronic hepatocellular disease typically look pretty good. That brings us to the later stages. You know what they say. In chronic liver disease, all roads lead to a liver-shaped rock? Or at least that's what they should be saying. That's right. Chronic hepatocellular diseases all have the potential to progress to cirrhosis, which makes cirrhosis the late stage. As we discussed earlier, the early stages of those conditions are inflammatory, either from the start, as in the case for chronic hepatitis, or after a period of purely fatty infiltration, as in the case for steatohepatitis. Over time, this chronic inflammation causes the normal liver tissue to become replaced by fibrosis. Eventually, the result is a scarred cirrhotic liver, or, here in the sketchy verse, a liver-shaped rock. Chronic cholestasis can also cause cirrhosis, but we'll come back to that in a bit. We devote 2 videos to cirrhosis later in this chapter, so for now, we'll just hit the highlights. When chronic hepatocellular disease progresses to cirrhosis, labs typically continue to exhibit a hepatocellular pattern. Most of the time, AST and ALT are mild or moderately elevated, just as in early disease. Occasionally, AST and ALT normalize in advanced cirrhosis. Remember, AST and ALT are released by injured hepatocytes. If enough normal liver tissue is replaced by fibrosis, there will be few hepatocytes left to injure. The result? A fall in serum AST and ALT. Early, well-compensated cirrhosis can actually be asymptomatic. Some patients have non-specific symptoms, such as fatigue. Decompensated cirrhosis, however, is a different story. At this more advanced stage, patients present with an array of symptoms, physical exam findings, and lab abnormalities. This may include portal hypertension, leading to ascites and esophageal varices, among other findings, and signs of hyperestrogenism, like spider angiomata and palmar erythema. Patients with decompensated cirrhosis may also develop hepatic encephalopathy. It is also at this decompensated cirrhosis stage that hyperbilirubinemia and jaundice first develop. Finally! Until now, bilirubin metabolism was able to keep up with demand, but now that system starts to break down, producing conjugated hyperbilirubinemia and jaundice. Hepatic synthetic function also becomes impaired at this decompensated cirrhosis stage. Decreased clotting factor synthesis leads to prolonged prothrombin time, while impaired albumin synthesis produces a drop in serum albumin. For more on bilirubin metabolism and tests of hepatic synthetic function, check out our abnormal liver lab sketch, if you haven't already. Patients with cirrhosis, regardless of the underlying cause, are also at risk of developing hepatocellular carcinoma. That wraps up our overview of the early and late stages of chronic hepatocellular disease. Now, let's move on to our DDX section. As you'll see, there are quite a few causes of chronic hepatocellular disease, but the vast majority of cases are caused by just 3 disorders: alcoholic liver disease, non-alcoholic fatty liver disease, and viral hepatitis. We'll cover these first. First up, alcoholic liver disease. The early stage of this disorder is known as alcoholic fatty liver disease. Yep, you guessed it. This is one of those disorders that starts with fatty infiltration. Hence this drunken warrior fraternizing near the fatty boar. Hepatic steatosis can develop after just a few weeks of consistent, heavy alcohol use. In some patients, persistent heavy drinking eventually leads to development of steatohepatitis. And if a patient with steatohepatitis continues to drink, they're at risk for progression to cirrhosis. As we covered in the acute liver sketch, patients with chronic alcoholic liver disease can have acute on chronic exacerbations, known as alcoholic hepatitis. Patients with alcoholic hepatitis are typically quite ill. Common symptoms include jaundice, anorexia, and right upper quadrant pain. Of course, patients with alcoholic liver disease will have a history of heavy alcohol use, but how much is too much? As it turns out, heavy drinking can be defined in 2 ways. If we use daily limits, heavy drinking is 4 or more drinks per day in men or 3 or more per day in women. Alternatively, weekly amounts can be used. Here, heavy drinking is defined as 14 to 15 drinks per week in men and 7 to 10 drinks per week in women. A standard drink contains about 14 grams of alcohol. This is equivalent to a 12-ounce beer, a 5-ounce glass of wine, or 1.5 ounces of hard liquor, about a shot. In addition to asking about alcohol consumption, you'll want to look for a few lab patterns that point toward alcohol as the cause of hepatocellular disease. First, look for an AST to ALT ratio of 2 or greater. This pattern is highly suggestive of alcohol-induced liver injury, in part because other chronic hepatocellular diseases rarely present in this way. In fact, most other conditions on our differential typically present with ALT greater than AST. In addition, look for significant elevations in serum GGT. This is an effect of heavy alcohol consumption itself rather than the liver disease. As we mentioned earlier, GGT can be elevated in any hepatocellular disease, often rising in parallel with alkaline phosphatase. That said, GGT is typically much higher when the hepatocellular disease is due to alcohol. That concludes our section on alcoholic liver disease. Next up on our differential is non-alcoholic fatty liver disease, also known as NAFLD. As the name suggests, the early stages of this disorder are characterized by fatty infiltration, but this time minus the alcohol. That said, NAFLD progresses through the same stages as alcoholic liver disease. First comes hepatic steatosis, which in this case is known as non-alcoholic fatty liver or NAFL. By definition, this stage is not inflammatory, but continued exposure to risk factors will lead to development of inflammation in some patients. At that point, the disease is known as non-alcoholic steatohepatitis, or NASH. Patients with NASH are at risk for progression to cirrhosis. In sum, NAFLD looks, walks, and talks like alcoholic liver disease, but, by definition, is not caused by alcohol consumption. So, then, what is responsible? The answer lies in this brave warrior's vice, those metabolic brownies. Patients with NAFLD typically have one or more components of metabolic syndrome. This includes obesity, hypertension, dyslipidemia, glucose intolerance, or overt type 2 diabetes. The pathophysiology is not completely understood, but insulin resistance plays an important role. Thanks to the obesity epidemic, NAFLD has quickly risen from obscurity to become the most common liver disease in developed Western nations. And as obesity spreads around the world, so too goes NAFLD. Of course, not every patient with risk factors has NAFLD. So how do we screen for the disease? The first step is imaging to look for fatty infiltration. This is most often done via ultrasound, although CT and MRI are alternatives. In fact, fatty liver is a common incidental finding when these imaging modalities are performed for other indications. On ultrasound, fatty infiltration causes the liver to appear hyperechoic. That's ultrasound lingo for bright, just like this bright mirror shield reflecting the sunlight. Unfortunately, imaging can only establish the presence of fatty liver. It cannot determine the underlying cause. Since alcohol abuse is another common cause of fatty infiltration, a diagnosis of NAFLD can only be made if the patient is not a heavy drinker. In addition, imaging can't distinguish between steatosis and steatohepatitis. Only a liver biopsy can tell the two apart. That said, biopsy is not required in every patient with NAFLD. That wraps up our discussion of non-alcoholic fatty liver disease. Of course, no gathering of ancient Greek troops would be complete without a few hippo warriors. Throw in a viral capsid light source, and you've got our recurring symbols for viral hepatitis. Both hepatitis B and C are common causes of chronic hepatocellular disease. Let's start with Hep C. Of all the hepatitis viruses, C is the most likely to become chronic. Let's break this down. By convention, acute hepatitis C refers to the first 6 months after exposure to the virus. If infection extends beyond the 6-month mark, it's considered chronic. Most patients who acquire the virus are unable to spontaneously clear it. As a result, Hep C becomes chronic in the vast majority of cases. This chronic infection is appropriately described as chronic hepatitis, since the virus is highly inflammatory. When it comes to clinical presentation, this virus is all about the long game. This miniature C symbol from our acute liver sketch is here to remind you that the Hep Z virus rarely causes symptoms during the acute phase. As a result, at this stage, most patients are unaware that they are infected. Sneaky, sneaky virus. Once chronic Hep C develops, the disease still progresses slowly. Most patients remain relatively asymptomatic for decades, and some may still be unaware that they are infected. After 20 to 30 years, a subset of patients, less than a third, will eventually develop cirrhosis. Like Hep C, the hepatitis B virus is an important cause of chronic hepatocellular disease. But this time, the boundary between acute and chronic is based on the chronicity of a lab test. A positive Hep B surface antigen for more than 6 months establishes the diagnosis of chronic hepatitis B. This test becomes positive anywhere from 1 to 10 weeks after exposure to the virus. But how often does Hep B become chronic? It depends on the patient's age at the time the virus was acquired. When adults become infected, the vast majority clear the virus on their own. Only 5% develop chronic infection. The reverse is true when the virus is acquired at birth. 90% of these infants will develop chronic infection. When Hep B is acquired in early childhood, chronic infection develops in 20 to 50%. So, how does Hep B present? In the acute phase, some patients develop symptomatic acute hepatitis. Others have few to no symptoms and may be unaware that they've acquired the virus. Chronic infection gets a bit more complicated. Here, there are several phases, which are defined by lab criteria. However, not all patients go through every phase. Most affected adults start in the immune-active chronic hepatitis phase, which is highly inflammatory. This is typically followed by an inactive carrier state, in which inflammation is minimal. In general, most patients with chronic Hep B are asymptomatic. As a result, some remain unaware that they have the infection. Over the course of years, a small percentage will eventually develop cirrhosis. Both hepatitis B and C are transmitted through body fluids, and they have similar risk factors. If you've watched our acute liver sketch, this section will look similar to the corresponding one on acute hepatitis B and C. They're the same viruses after all. But when it comes to Hep B, one factor does become more important in the chronic setting: a person's country of origin. In areas where Hep B is endemic, including parts of Asia and Africa, the virus is primarily acquired at birth or in early childhood. As we've established, Hep B is far more likely to become chronic at such an early age. In the U.S., patients who have emigrated from endemic areas represent more than half of the current chronic Hep B cases. Hepatitis C is also more prevalent in parts of Asia and Africa, but the vast majority of chronic Hep C in the United States is acquired on U.S. soil. Within the U.S., the most common mode of transmission for both hepatitis B and C viruses is via IV drug use with shared needles. That said, any sort of contaminated needle can transmit these viruses, so ask about a history of tattoos or body piercings, and be on the lookout for healthcare workers with an accidental needle stick. Both viruses can also be transmitted sexually, although this type of spread is more common for Hep B. Patients at increased risk include those with multiple partners and men who have sex with men. Now that we've established the risk factors, how do we test for these viruses? Screen for chronic hepatitis B by ordering 3 tests. First, Hep B surface antigen, represented by the spikes adorning the surface of this warrior's armor and shield. A positive surface antigen indicates active infection, acute or chronic. As we mentioned earlier, this test is also used to determine the chronicity of the infection. Specifically, a positive test for more than 6 months established the diagnosis of chronic Hep B. Second, the Hep B core antibody. This is typically ordered as a total antibody level, which includes both IgM and IgG. But here in the world of chronic liver disease, it's the IgG version that will be consistently elevated, hence the IgG emblem on this shield's core. Third, the Hep B surface antibody. This test is negative in chronic hepatitis B, and acute Hep B for that matter. A positive test would indicate immunity. Definitely not the case here. To indicate a negative test result, we've included this broken antibody sword, recently fallen from the warrior's surface onto the ground. How does this compare to screening for acute Hep B? Well, there are a lot of similarities. In both cases, you can expect the Hep B surface antigen to be positive and the surface antibody to be negative. The one difference relates to the Hep B core antibody. In the acute setting, only the IgM version will be positive. The IgG hasn't yet had time to develop. But by the time the virus becomes chronic, most of the core antibody has class switched to IgG. Screening for chronic hepatitis C is quite a bit simpler. There's just one test, the anti-Hep C antibody. This is an IgG, although you won't normally see that specified. But still, check out the IgG sword wielded by this C-themed warrior. Wow, dude, take it easy. Can't you tell it's party time? Once again, let's compare acute and chronic. In the acute setting, a Hep C viral RNA is ordered in addition to the anti-Hep C antibody. This is because the antibody doesn't become positive until 12 weeks after exposure. The RNA becomes detectable sooner, allowing for earlier diagnosis. The RNA will also be positive in patients with chronic Hep C, but in the chronic setting, the viral RNA is used as a confirmatory test rather than for screening. Before we move on, a quick word about the rest of the hepatitis viruses. As we discussed in the acute liver sketch, Hep A and E only cause acute hepatitis, not chronic, so naturally they didn't make it into this sketch. Hep D, as in dog, is a little different. This virus can become chronic, but because it's so uncommon, it is not considered a significant cause of chronic hepatocellular disease, at least in the US. That concludes our section on viral hepatitis. Let's switch gears into the hereditary causes of chronic hepatocellular disease. First up, hereditary hemochromatosis. This disease is most commonly caused by mutations in the HFE gene, which leads to increased absorption of iron from the intestines. The resulting iron overload causes iron to deposit in tissues, including the liver. The resulting chronic liver disease presents similarly to the other conditions on our differential. The early stages are asymptomatic, although hepatomegaly and elevated AST and ALT may present. Continued deposition of iron in the liver leads to fibrosis and eventually cirrhosis. That said, it takes decades to accumulate enough iron to cause the clinical manifestations of this disease. As a result, symptoms don't begin to develop until after age 40, in men anyway. In women, symptoms develop even later, after age 50. This is related to the fact that most women go through menopause around this age. See, most premenopausal women are chronically losing iron, thanks to menses, pregnancy, and lactation. As a result, women with hemochromatosis are relatively protected against significant iron overload, at least until menopause. Hereditary hemochromatosis is inherited in an autosomal recessive manner. As a result, some patients may have a family history of the disorder. So don't forget about that family history. Patients may not be familiar with the actual disease name, so asking about relatives with liver problems is a good place to start. The liver isn't the only organ affected by hereditary hemochromatosis. Iron deposition in other tissues produces a variety of other clinical manifestations. Deposition of iron and melanin in the skin can lead to bronze pigmentation. Meanwhile, iron accumulation in the pancreas can cause diabetes mellitus. The combination of these two manifestations is classically referred to as bronze diabetes. Arthritis is another common symptom. The joint disease is, of course, a result of iron accumulation. The MCP joints are most commonly involved. Men may also present with erectile dysfunction. This is usually a result of secondary hypogonadism from iron deposition in the anterior pituitary. Iron deposition in the heart, meanwhile, can cause dilated cardiomyopathy. Patients may present with arrhythmias or heart failure. Screen for hemochromatosis by ordering iron studies. This typically includes serum iron, total iron binding capacity, also known as TIBC, and ferritin. Which of these three labs is the best screening test? None of the above. The most useful number is actually the transferrin saturation. This is calculated by dividing the serum iron by the TIBC. A transferrin saturation above 45% suggests an iron overload condition, like hereditary hemochromatosis. The serum ferritin will also be elevated in affected patients. However, the ferritin is commonly elevated in other liver diseases, making it less useful as a screening test for hemochromatosis. Up next, Wilson disease. In this genetic disorder, mutations in the copper transporter ATP7B lead to impaired copper transport and excretion. Over time, copper builds up in the liver, brain, and cornea. Wilson disease can present with a variety of hepatic manifestations. As we discussed in the acute liver sketch, some patients initially present with acute hepatitis or acute liver failure. But most skip right past the acute manifestations and instead present with chronic hepatitis, or if the disease is more advanced, cirrhosis. Wilson's can also cause hepatic steatosis, which may initially be mistaken for NAFLD. Wilson's disease typically presents at a younger age than most other conditions on our differential. The average age at diagnosis is 13 years, with the majority of patients presenting between the ages of 5 and 35. Like hereditary hemochromatosis, Wilson's disease is inherited in an autosomal recessive manner. So, once again, some patients may have a family history of the disorder. The disease can also cause neuropsychiatric symptoms, thanks to deposition of copper in the brain. The order in which symptoms develops varies considerably. In some patients, hepatic symptoms precede neuropsychiatric manifestations, but the inverse can also be true. Some of the more common neurologic manifestations include dysarthria, tremors, and Parkinsonism, including cogwheel rigidity. Patients may also demonstrate behavior changes or psychiatric symptoms such as depression. If Wilson disease is suspected, perform a slit lamp eye exam to look for Kayser-Fleischer rings. These golden brown rings in the peripheral iris result from deposition of copper in the cornea. The presence suggests Wilson disease, but is not diagnostic. The screening test for Wilson disease is a serum ceruloplasmin level. Ceruloplasmin is a copper transport protein. In patients with Wilson's, incorporation of copper onto ceruloplasmin is impaired. Without bound copper, ceruloplasmin has a shorter half-life. As a result, expect the ceruloplasmin level to be low in patients with the disease, hence the oh-so-saggy cerulean blue shorts. Really, dude? Is that necessary? If you watched our acute liver video, you may recall that in the acute setting, the serum ceruloplasmin level isn't a terribly reliable screening test. Both falsely elevated and falsely low test results are not uncommon in patients with acute liver disease. Fortunately, the test is more reliable here on the chronic side. In other words, most patients with chronic hepatocellular disease secondary to Wilson's will have a low serum ceruloplasmin level, just as expected. That wraps up our discussion of Wilson's disease, and brings us to our last hereditary condition, alpha-1 antitrypsin deficiency. This disease is caused by mutations in the gene encoding for alpha-1 antitrypsin, a protease inhibitor synthesized by hepatocytes. The disorder leads to clinical manifestations in two main organs, the lungs and the liver. Most patients with liver disease are homozygous for the Z mutation, meaning that they have the ZZ genotype. The alpha-1 antitrypsin variant produced by this mutation is prone to abnormal folding and aggregation within hepatocytes. This intracellular accumulation of abnormal alpha-1 antitrypsin is responsible for the liver disease, which typically presents with chronic hepatitis, or if the disease has progressed further, cirrhosis. The lung disease results from a different mechanism. Normally, alpha-1 antitrypsin protects the lungs from degradation by elastase. In patients with the disorder, too little alpha-1 antitrypsin in the lungs allows elastase to wreak havoc on the lung tissue. The result? Emphysema. This disorder has a variable age of onset. Some patients present in childhood, while others present in adulthood. Unlike the two other genetic disorders in this sketch, alpha-1 antitrypsin deficiency is not autosomal recessive. Instead, it's inherited in an autosomal codominant pattern. In this type of inheritance, heterozygotes may have an intermediate form of the disease. In the case of AAT deficiency, heterozygotes who smoke are at an increased risk of lung disease compared to smokers in the general population. Like hereditary hemochromatosis and Wilson disease, patients with alpha-1 antitrypsin deficiency may have a family history of the same disorder, so don't forget to ask about relatives with liver disease and, in this case, lung disease as well. Screen for AAT deficiency by getting a serum alpha-1 antitrypsin level. This will be low if the disease is present. You know, deficiency and all. Hence this ancient Greek level, down low on the ground. That wraps up our discussion of the hereditary causes of chronic hepatocellular disease. Now, let's move on to some of the less common acquired disorders. First up, autoimmune hepatitis. The clinical presentation of this disease is quite variable. As we discussed in the acute liver sketch, some patients initially present with acute hepatitis, or, less commonly, acute liver failure. This acute disease can then become chronic, but some patients never develop acute symptoms. Instead, these patients present for the first time with signs of chronic hepatitis, or if the disease is more advanced, cirrhosis. Autoimmune hepatitis predominantly affects women. It can present at any age. Patients may have another concurrent autoimmune disorder, like rheumatoid arthritis, autoimmune thyroid disease, or inflammatory bowel disease. Screening for autoimmune hepatitis in the setting of chronic liver disease is identical to screening in the acute setting. You'll want to test for 3 specific autoantibodies: anti-nuclear antibodies, anti-smooth muscle antibodies, and anti-liver kidney microsomal 1 antibodies. At least one of these three is elevated in most cases of autoimmune hepatitis. In addition to the specific antibody test, obtain a serum IgG level. This will be elevated in most patients with the disease. That wraps up our autoimmune hepatitis section. Next up, drug-induced liver injury. Many drugs and supplements can cause hepatotoxicity, although for each drug, the incidence is very low. The vast majority of drugs that cause liver injury do so at therapeutic doses. This is sometimes referred to as dose-independent or idiosyncratic injury. If you watched our acute liver video, you'll recall that there was one exception in that setting, acetaminophen, which causes liver injury only in overdose. But here in the chronic world, acetaminophen doesn't play much of a role, and most drug-induced liver injury occurs at therapeutic doses. Drug-induced liver injury is categorized by the type of liver disease it resembles. Two phenotypes are relevant here in our chronic hepatocellular disease differential: chronic hepatitis and fatty liver. Both are typically seen only after long-term use of the offending drug. In both, most patients present with asymptomatic mild or moderate elevations in AST and ALT. Progression to cirrhosis is relatively rare. Drug-induced chronic hepatitis often mimics chronic viral hepatitis. In some cases, autoantibodies are positive, similar to autoimmune hepatitis. The antibiotics nitrofurantoin and minocycline are known causes of this type of liver injury. The fatty liver phenotype most closely resembles non-alcoholic fatty liver disease. Methotrexate and amiodarone can both cause this type of liver injury. Both drugs are also notorious for causing fibrosis and even cirrhosis. Of course, these are only a few of the many drugs that can cause these types of liver injury. A comprehensive list can be found on the LiverTox website at livertox.nih.gov. And, of course, in any patient liver disease, don't forget a thorough medication history, including over-the-counter medications and supplements. You never know when drug-induced liver injury is lurking around the corner. Next up, celiac disease. Patients with celiac disease have an intolerance to gluten, a family of proteins present in wheat, barley, and rye. This intolerance results in immune-mediated injury to the mucosa of the small intestine, producing malabsorption. But it's become increasingly clear that celiac disease can also affect other organs, including the liver. The mechanism? Autoantibodies may be involved, just as they are in the intestines. In addition, increased intestinal permeability may allow toxic or inflammatory substances into the portal circulation, and subsequently, the liver. This liver involvement typically manifests as mild to moderate elevations in AST and ALT. These labs typically normalize once gluten has been removed from the diet, suggesting a causal relationship. Cirrhosis secondary to celiac disease is rare, but has been reported. Patients with celiacs may also display some of the classic disease symptoms. Thanks to malabsorption, patients may present with steatorrhea, large, fatty, foul-smelling stools that tend to float, just like this floating fatty waste. Oh man, never knew seal poop could smell so rancid. Screen for celiac disease with serologic testing. Start by ordering a tissue transglutaminase IgA antibody, which is the single best test for detecting the disease. That wraps up our section on celiac and our differential for chronic hepatocellular disease. Next, let's run through the workup for a relatively common scenario, an asymptomatic patient with mild or moderate elevations in AST and ALT. In other words, the classic presentation of early chronic hepatocellular disease. But we've jumped ahead of ourselves because the first step is actually to repeat the lab tests to confirm that the abnormalities are real. Once that's been done, it's time to start the workup. The initial evaluation includes a few crucial pieces of patient history. You'll want to ask about alcohol consumption, since, of course, prolonged heavy drinking suggests alcoholic liver disease. To look for evidence of drug-induced liver injury, get a thorough medication history, including over-the-counter drugs and supplements. Look for some of the more notorious offenders, like methotrexate, amiodarone, and antibiotics. But keep in mind that many other drugs can also cause liver injury. Let's move on to lab tests and imaging. The first set of tests is typically ordered in all patients with mild or moderate AST and ALT elevations, including those with a clear history of heavy drinking. It's not uncommon for a patient to have more than one chronic hepatocellular disease. We'll start with viral hepatitis serologies. Screen for chronic hepatitis B with 3 tests: Hep B surface antigen, core antibody, and surface antibody. This last one will be negative in a patient with the disease. Screening for chronic hepatitis C is a little easier. Just order a Hep C antibody. This initial workup also includes iron studies to look for evidence of hereditary hemochromatosis. The best screening test is the transferrin saturation, calculated by dividing the serum iron by the TIBC. In patients with the disease, both the transferrin saturation and serum ferritin should be elevated. To screen for NAFLD, order an ultrasound to look for that bright, fatty infiltration. That wraps up the initial eval. By this point, most patients will have a diagnosis. In those with a history of significant alcohol consumption, the diagnosis of alcoholic liver disease can also be made at this point, without the need for additional workup. But in all other patients, if initial testing fails to reveal a cause, consider a second set of labs to screen for less common conditions. This includes a serum ceruloplasmin level to look for Wilson disease. Ceruloplasmin will be low in affected patients. It also includes a serum alpha-1 antitrypsin level to screen for ATT deficiency. This will also be low in patients with the disease. In addition, screen for autoimmune hepatitis with a serum IgG level and 3 autoantibodies: anti-nuclear antibodies, anti-smooth muscle antibodies, and anti-liver kidney microsomal 1 antibodies. And finally, order a tissue transglutaminase IgA antibody to screen for celiac disease. But what if this second round of testing also fails to reveal a cause for the AST and ALT elevations? Well, consider looking outside the liver. As it turns out, elevations in AST and ALT can also come from skeletal muscle. Congenital and acquired muscle disorders, as well as muscle trauma or intense exercise, can produce this effect. Notice this statue's cracked muscles near the toasting malt glasses. If muscle is the source of the elevated AST and ALT, other muscle enzymes will also be elevated. So, if AST and ALT are persistently high but workup for hepatocellular disease is negative, screen for muscle disorders with serum creatine kinase and aldolase levels. At least one of these should be elevated if a muscle disorder is to blame. If all that workup fails to reveal the underlying cause, consider a liver biopsy to help solve the mystery. Biopsy is not done routinely because it is an invasive procedure, but it can provide information about the underlying etiology as well as the stage of the liver disease. Now that you're familiar with the workup of an asymptomatic patient with mild or moderate elevations in AST and ALT, let's change the scenario slightly. What if, instead, our patient presents with symptoms and signs of cirrhosis, etiology unknown? Fortunately, the majority of the workup we just covered also applies to this case. Since all of the chronic hepatocellular diseases can cause cirrhosis, the first 2 rounds of testing are identical. To recap, the initial eval includes screening for alcoholic liver disease and drug-induced liver disease by history. It also involves lab testing for hepatitis B and C as well as hemochromatosis, and an ultrasound to screen for NAFLD. The second round includes testing for Wilson disease, alpha-1 antitrypsin deficiency, autoimmune hepatitis, and celiac disease. We'll drop the third round, testing for muscle disease, since the presence of cirrhosis indicates liver involvement. The fourth round, liver biopsy, still applies. In a suspected cirrhotic, a biopsy may be performed more readily than in a completely asymptomatic patient, but it is still not performed routinely. But before we get to liver biopsy, we need to consider another class of disease, because chronic cholestasis can also cause cirrhosis. We covered cholestasis in our abnormal liver lab sketch, so we'll be brief this time round. Patients with cirrhosis secondary to cholestasis typically present with a cholestatic lab pattern rather than a hepatocellular one. Recall that the cholestatic pattern is characterized by marked elevations in alkaline phosphatase. AST and ALT may be normal or mildly elevated. In addition, conjugated hyperbilirubinemia occurs relatively early. In a patient with cirrhosis and a cholestatic lab pattern, workup includes testing for the two main causes of chronic cholestasis. The first is primary biliary cholangitis, or PBC. In this disorder, autoimmune destruction of small intrahepatic bile ducts leads to chronic cholestasis and, eventually, cirrhosis. Screen for PBC by ordering an antimitochondrial antibody. This test is both sensitive and specific for the disorder. Simple. The second condition is primary sclerosing cholangitis, or PSC. In this disorder, inflammation, fibrosis, and stricturing of intra- and extrahepatic bile ducts are responsible for the chronic cholestasis. Unfortunately, PSC doesn't have a convenient lab test. Ultrasound may demonstrate non-specific abnormalities of the bile ducts, but typically can't cinch the diagnosis. If PSC is suspected, the test of choice is magnetic resonance cholangiopancreatography, or MRCP. In a patient with the disease, MRCP will demonstrate a beaded appearance of the bile ducts, thanks to the underlying strictures and dilations. For more on PBC and PSC, check out the cholestasis section of our Abnormal Liver Lab sketch. And that, my friend, wraps up our chronic liver disease DDX sketch.